TopMedTalk. Hello everyone. We have a session actually that I'm quite interested in, actually quite dear to my heart at the moment. So we're doing a perioperative pain management session, but obviously we're mostly focusing on opioids and opioid reduction and the opioid epidemic. And we have 3 speakers from various places around the world. At this point, the reason I'm quite interested, I was recently asked, we heard about MOOCs the other day, the massive online courses, and UCLH has just released a opioids in surgery MOOC, opioids and surgery on Future Learn. I think 1,500 people have signed up for the first run. If this topic tickles your interest, do go and look up that MOOC. Now, first speaker, previous session as well, is a friend of mine, Tim Miller, professor at Duke, former boss as well. We became friends after he was my boss. He's chair of the General Vascular and Transplant Division at Duke University and is only going to come talk to us about the opioid epidemic and opioid reduction strategies. So thank you, Tim.
All right, thank you very much. This is obviously a huge topic, so I'm just going to do a very high-level overview. So I'm basically going to speak a little bit about the opioid epidemic, well placed to do that, living in the US, a bit about the problem of persistent opioid use after surgery, why we use opioids in the first stage, some strategies that again are very high level for reducing opioids, touch on opioid-free anesthesia and analgesia, that's a little bit topical, and throughout this refer to we've had several pokey conferences on opioid minimization, so it's just not just my view you'll get, but some consensus of views that have been developed through these conferences. So the opioid crisis, this is the New York Times. This is back in 2015. They say that opioids is the worst drug crisis in American history, killing more than 33,000 people in 2015, equal to the number of deaths of car crashes, and for the first time ever, greater than gun homicides. So in the US, if more people are dying of something than gun homicides, then it's probably bad. This has continued to get worse, as you can see, since that New York Times article in 2015. The number of people that have died from opioid deaths has more than doubled in the US, predominantly males, although a slight increase in females as well. And if you look at the type of opioids, you see really the big standouts of 2015 is the synthetic opioids, primarily fentanyl, which are coming over from unregulated from China. Various other categories, but there is in blue a persistent opioid death from prescription opioids. And we know that in the US that a lot of prescription opioids are prescribed postoperatively, too much. Some of this goes into the hands of patients. Many of them go into the hands of relatives and friends. And also there is a significant link between using prescription opioids, not being able to get your prescription, and then switching to fentanyl, which has had this big spike in death. So this is a problem, and it's a significant problem in the US. Incidentally, it has finally seemed to have plateaued. I haven't got the data here in 2023, 24. So there is hope, but it's been a massive crisis. So let's see some facts about period use of opioids. The average person has 9 operations in their lifetime. I don't know where you are. I'm on 2, so I guess I've got a few to go. Interestingly, this is a classic paper from 1980 in the New England Journal. We conclude that despite widespread use of narcotic drugs in hospitals, that the development of addiction is rare in medical patients with no history of addiction. And I'm sure many of you, the audience, know that this was taught for a number of years, that if you have periop opioids, you don't get addicted. Really, Chad Brummett and others have done a lot of work in the US to try and dispel this myth, publishing that 3 to 7% of opioid naive patients still take opioids 1 year after surgery. And this was his classic paper in JAMA Surgery, looking at the incidence of new persistent opioid use by surgical procedure. You can see a number of surgical procedures here, not what you would think of as major procedures. And again, perhaps highlights how much post-op opioids are prescribed historically in the US. Even when I went to the US, I was amazed how much opioids were used compared to the opioids that are used in the UK. And you would probably think many of these patients would not even be given any post-op opioids. But they are, and a significant number still taking them chronically. And this was at 180 days after the procedure. So why are we using opioids? Well, this is Paul Janssen. He first synthesized fentanyl back in 1960, and very shortly after that, there was a lot of publications about using high-dose fentanyl, particularly in cardiac surgery. But we all know it blunts sympathetic and responses for doing the airway and surgical incision, although there are other ways we can do this. Classically, we use opioids. It's cardiovascularly stable. And, of course, we have reversal agents if needed. But opioids, of course, have problems. They've got a high risk of respiratory depression, may have effects upon cancer. You can get tolerance and hyperalgesia. And, of course, we have the well-known opioid side effects, nausea and vomiting, ileus, urinary retention, etc., which can have negative effects on length and quality of recovery. And TJ Gann did this study 20 years ago now, seeing what patients would rather experience. And the majority of patients would rather have adequate pain relief, but not have some of the side effects of opioids, such as nausea, vomiting, constipation. And I think I would firmly put myself in that camp. I did a study with TJ 10 years ago now, looking at pain management over the years. And you can see that pain is still an issue. It's not as if we've solved this issue. Significant numbers of patients, this is self-reporting, report severe or moderate or severe pain after surgery. And this really hasn't changed over the years. So what opioid reduction strategies are available? I'll go back to our POKI1. This was particularly looking at enhanced recovery after colorectal surgery. One of the groups really looked at how we manage pain after surgery. And this was back in 2016. And again, staying at a very high level, one of the infographics we came out with was really to try and emphasize that we're not looking for a pain score of 0. We're looking for optimal analgesia after surgery. And we still have this on the walls in our pre-op clinic to try and emphasize and educate patients that we want optimal comfort to enable the fastest recovery with fewer side effects. And if that's a pain score of 3 or 4 and you're comfortable and you can take round the clock non-steroidals and paracetamol, should I say, for a UK audience, then that's in a good place to be. And again, at the bottom, encouraging that post-operative drinking, eating, mobilizing, we added sleeping in as well, which I think is very important. How you do this, of course, is going to be dependent on the surgery, the patient, the institution. But in general, our recommendations were education, round-the-clock non-steroidals, acetaminophen, gabapentinoids, and we'll come on to that in a second. Obviously, local anesthetic wherever possible. We were very heavy epidural users for a while. We still use some interesting called opioid, and now we've gone more to rectus sheath blocks. I know there's trials going on with continuous rectus sheath catheters, etc. And again, whatever works in your institution and can be implemented easily for your patients. And then, of course, we have other adjuncts such as ketamine, lidocaine infusions, etc. And I also think it's important that you have a rescue plan. When a patient gets severe pain, again, it's not first line just turning to opioids. It's, again, having a pyramid of techniques that you can do so that in the middle of the night, and they're not just getting opioids as first line if they do need any rescue analgesia. Importantly, and again, this is a US slide, but importantly, you can do all you want for opioid reduction, but you've got to make sure that it continues into the post-operative period. And I think this was a very interesting study a few years ago, showed dramatic reduction in opioids intraoperatively on the left with the enhanced recovery protocol as implemented, but the amount of opioids that were given after discharge did not change. So a lot of centers haven't addressed that. So it's still the intern or the resident writing that opioid prescription post-op, and it wasn't the focus that needed reducing as well. And I think this is an important element shown in this study. So evidence evolves, and I think, again, within enhanced recovery, I think there's a huge potential for large-scale observational data to improve outcomes. And this is from our CAPER unit at Duke. They did several large-scale observational studies looking at the use of gabapentinoids within enhanced recovery pathways, either for colorectal surgery and another study for hip and knee. Not got time to show you all the data, but essentially they consistently showed that gabapentinoid use was independently associated with a higher odds of non-invasive ventilation and naloxone use. And this is from the Premier database, is a sort of large billing database, so it's not very granular, but you can get a large N, look at large number of patients and get you some real world data. And they concluded routine perioperative use of gabapentinoids needs to be reconsidered with the associated risk. And we removed the routine use of gabapentinoids from a lot of our periop pathways. So what about opioid-free anesthesia? I'm going to touch on this as it's quite topical and a little bit controversial. So we had another pokey in Nashville where Andy Shaw was at the time. This was initially titled opioid-free anesthesia, or the group decided to change it to opioid minimization to widen the topic. But they looked really at three main questions. What are the potential strategies for presenting persistent post-operative opioid use? Is opioid-free anesthesia routine and feasible? And is it associated with equivalent or superior outcomes compared to opioid minimization in the perioperative period? And as you may imagine, it wasn't particularly easy to answer any of those questions, but I will give you the consensus statements that were produced. There are insufficient data to recommend a specific strategy for prevention of persistent post-operative opioid use. Studies have largely focused on short-term rather than long-term outcomes, and so we need more long-term outcomes and follow-up to look at strategies, in particular with regards to chronic pain. And again, with regards to opioid-free anesthesia and analgesia is feasible, and it's suggested that it can be appropriate at times. However, again, insufficient data to determine benefits and harms compared to opioid minimization. Particularly highlighted that terminology is confusing. Opioid-free anesthesia, opioid-free analgesia, what exactly does it mean? There have been a couple of larger studies since then, which I think highlight some of the concerns that people have about this literature and making large changes and whether you're actually giving any benefit when you change one strategy from another. So this was the first multi-center randomized controlled trial of opioid-free anesthesia. Interesting that the protocols vary enormously when you think about opioid-free or opioid minimization. They had a GA with a standard anesthetic featuring lidocaine and ketamine in both groups, and then one group got Remi on top of that, and the opioid-free group got dexmedetomidine. And so the primary outcome seems sensible, a composite of post-op complications related to opioids in the first 48 hours. However, I think this study illustrates, there's no free lunch. The study was stopped early because of severe bradycardia in the dexmedetomidine group, which, as you know, is a known side effects of dexmedetomidine. Is dexmedetomidine available in the UK yet? It wasn't for a long period of time. It is. The primary outcome occurred more commonly in the opioid-free group. So they got more of those side effects in the opioid-free group than the remifentanil group. This study did not work. And I think it illustrates the dangers of perhaps swapping one technique for another. And we have to be careful what we do. This was another study recently published this year in Anesthesiology, single center, 136 patients, major surgery, typically requiring post-operative opioids. I'd say a lot of this was plastic, and they allowed regional anesthesia or local infiltration. So it was a pragmatic study. Interesting to see the protocol very different. Opioids and a low ketamine bolus in both groups, but the opioid-free group had infusions of at least 2 of ketamine, lidocaine, clonidine, and magnesium, and the majority of patients received all 4. Both groups had acetaminophen and nefapam, interestingly enough, and the primary outcome, quality of life at 24 hours. And you can see in this study, there really was no difference in the quality of life. There was a slight statistical difference, but no clinically significant difference compared to standard of care. No difference in PACU opioid consumption, no difference in chronic pain or quality of life. So really a negative study, no benefit of this opioid-free technique. Finally, just go on to cardiac surgery. POCI 8 was focused on opioid management within cardiac surgery. It has historically still been the area where high-dose opioids have been used. And similar infographic that was produced, really questioning the need for high-dose opioids in cardiac surgery. It's unnecessary, potentially harmful, and really suggesting that cardiac surgery should also be somewhere where we look to minimize opioids and use multimodal analgesia. And there is really no strong evidence that high-dose opioids are beneficial in this population. And again, when we look at the type of multimodal analgesia that should be given, it's very similar. And you see here we have in the boxes recommended, in the dashed boxes considered. So again, education, acetaminophen, gabapentinoids are now in the consider as a non-steroidals for cardiac surgery. Ketamine, dexmedetomidine is used much more in cardiac surgery because of its superior, wake up. And again, opioids, etc., in the dashed boxes at the bottom, a part of your armamentarium, but the days perhaps of giving huge, large dose opioids may be diminishing. So to summarize, I think, perioperative opioid use has side effects, as we all know. Opioid-sparing, opioid-free anesthesia is not one technique, but rather a huge variety of techniques. That a lot of these drugs may have side effects by themselves, as I've shown. So, of course, more research is needed. This should include both randomized controlled trials and using this large database that we have. Balance is key. It's not what you do, it's how you do it. Thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.